Okay, let's review. This should take, I think, 30 minutes. We'll see. Hopefully, that's about where I am. All right. So the first thing you need to know is the difference between communication, language, and speech. Well, communication is the sharing of information across a medium, right? So two things that are sharing information, they don't need to be even alive, right? Just like those pendulum clocks. They're sharing information between the two of them, so they're communicating, but they're not necessarily, they're definitely not alive. But there's communication there. Language does require a thinking, party with it. So that's going to be actually communicating thoughts. And a language is going to be a code that has agreed upon rules, right? And so we've got a bunch of rules that we'll talk about later, but syntax, semantics, pragmatics, they're on this slide, right? Some of them are. Morphology, phonology, all those rules that we use to communicate. And they can also be, those different elements of the language can be combined to form new parts of the language. So you can create new, you can convey new ideas, is what I want to say. And then speech is just like the actual way that you're conveying that language, right? So we have a language, English in this case, and right now I'm using speech to convey it to you. I could write everything down like you're seeing on the slideshow here. I could sign it to you, all sorts of different things, right? So they're kind of, if you think about an inverted pyramid, communication is going to cover a whole bunch of things. Language is going to cover a lot less, and then speech is a very specific thing, right? It's a spoken part of the language. An impairment versus a disability, well, so an impairment is just like, is there a change in function, a diminished amount of functioning, right? So we can say that there is mild, high-frequency hearing loss. That would be an impairment. But is it a disability? Well, a disability comes in when that changes the way that someone functions in their job or in society, or the way that they want to live their life. So you may have an impairment that doesn't affect the person at all, and it's not a disability. So then we've got organic versus functional. An organic disorder is one where we have an identified cause, right? Functional is just going to be one that kind of presents itself, and we don't really know what caused it. So the really easy, obvious one here is a stroke versus the lisp that I have. A stroke is organic. We know there's the cause. This happened. And functional is my lisp. We don't really know what caused it. That's also going to be a good distinction for developmental versus acquired. So let me think of, speech problems associated with cleft palate. That is organic. We see a cause, right? We know that you're not going to be able to say "buh" very well because you can't close off your nasal passage with a cleft palate. So that's going to be definitely an organic disorder. But again, the lisp, functional, we don't really know what caused that. Developmental versus acquired, well, here is the stroke again is acquired. I mean, someone has progressed for some time as a normal communicator, and then all of a sudden something's happened and they're not able to. It doesn't have to be in later life, like strokes are usually in middle age to elderly. It can be, at age 5, something can happen. You can have TBI at 5, and then you can have a speech problem. So that would still be acquired. Developmental is something that just shows up during development, right? And so again, the lisp that I have is a developmental thing. It's not something that's been acquired. But if I talked totally normally and then I fell down one day and hit my head, and then I had the lisp, that would be acquired. All right. So I've actually got the next few things up in several different places on this review, and that's because, well, I think I have them in 2 different places. In our ASD lectures, you heard form, use, and content. And we didn't talk about it in that way. We did talk about those, but you can kind of subsume some of these things into those different areas. So I'll talk about those when we get to ASD. Semantics is just the relation of, thoughts and feelings to words, so choosing the right word in the right situation, that's semantics. Lexicon is your internal knowledge of words, so what all the words that you know is your mental lexicon. Syntax is how they're used together, so proper grammar. And then pragmatics is all of the social conventions, right? A lot of them are spoken conventions, but we've also got some like eye contact, we've got proximity, all sorts of different things like that. That's all pragmatics. Distinctive features is just that older model where everything could be broken down into zeros and ones. Remember I was talking about how that's how computers were constructed back in the day. And they still run that way, but we have algorithms that can do non-binary things. And so the speech scientists were trying to figure out a way to model speech with just like something is turned on, something is turned off. So this is a fricative, yes. It is a velar fricative, yes. And so if we could do that, we could perfectly model speech being in exactly the same place every time to make perfect speech. Well, the problem with that is we know that we don't say things exactly the same way every time, right? So if you say fan and fad, the F and the A are going to be produced differently. Well, the F and the A are going to be produced differently. The N and the D aren't in both words, so of course they are. But fan, fad, you can hear how the A has a very different quality to it. And the F is, when you're just actually speaking them, the F is held a little bit longer. I'm obviously over accentuating it, but the really, noticeable difference is fan, fad. There's more of a nasally content to the A before the N, which makes sense. N is a nasal. So it's kind of like we're preparing to go to that nasal in the consonant. Distinctive features wouldn't let us do that. And so it doesn't properly model speech because we don't do perfect robotic 0 and 1 kind of speech. And the approach has changed by trying to model those things. So we've got more probabilistic models now that will take into account what's being voiced before and after and try to accommodate that way. But then, like I said, it's going to change. It's going to be refined with more technology. We'll be better at modeling speech. So, all right, speech anatomy. The only thing a muscle can do is contract. Well, and relax, I suppose, if you want to call relaxing a thing that it can do. But if it's in its relaxed state, is like its default, the only thing it can do is contract, right? That's it. So this is a big thing to know when we talk about anatomy things in here. Muscles are only going to contract. And when they contract, that means they get shorter. It's also going to be really important for you to remember this when you go into your anatomy class. So muscles can only contract. If you see a muscle and it's connected between two things, when it contracts, those things are going to get closer together, right? It might take kind of a weird path. So the bicep is attached up here in the shoulder and also down here in the forearm, and it gets shorter and it moves. It's not like pulling my forearm in. So it's kind of taking this path where it's shortening and it's bringing the forearm closer, because that's bringing this and this closer together. So it might take kind of a funky path based on where the tendons are, how the, where the joint is, and all sorts of things like that. But all that's happening is the muscle fiber is getting shorter. All right. So what is the power source for speech? Breathing. And what is the sound source for speech? The vocal folds. You combine those, the power source, you take in a breath, and then you can force it out through your larynx between your vocal folds. So what you need is breath inside of your body that can be pushed through, and there's the power. And then when you vibrate the vocal folds, that creates the sound source. It's an unregulated source at that point. You need to use the resonators and the articulators to like mold it into an actually recognizable speech sound. But the main like raw things are power and power source, sound source, breathing, vocal folds. The diaphragm is the main breathing muscle. It's a large kind of parachute-shaped muscle that's, in your thorax, kind of right here. I don't know, can you see that? Or is this video not? No, you cannot see that. So it's kind of like right around here, and it's going to, when you breathe, when you inhale, it pushes downwards. So it's going to make more space in the thoracic cavity. The lungs are going to inflate to fill that area, and that's breathing. There are other muscles involved, but you will absolutely learn those in your anatomy class. We might talk about a couple of them when we talk about different sorts of speech issues, but for now, the one that's really important is the diaphragm. Speech breathing versus quiet breathing. So quiet tidal breathing is mostly governed by the diaphragm. The diaphragm will contract, and then it'll just relax. And then gravity and elastic forces of the lungs and the thoracic cavity will kind of make you exhale. So the diaphragm contracts, you inhale, it relaxes, these other forces take place, these passive forces, and you exhale. For speech breathing, though, you need to use a lot of other muscles. So all of the muscles of forced inspiration, so that would be like things that are not just the diaphragm, and all the muscles of forced expiration. One of the large ones of those is the abdominal muscles, because you're going to like tighten your abs and force air out. That's why your abs hurt when you laugh a lot, because you're forcing air out. So it's kind of like you're getting a kind of a workout, kind of an ab workout. So anyway, speech breathing is going to require active muscular control of the inspiratory muscles and the expiratory muscles, much more than just quiet tidal breathing. That's all you need to know for now. You'll get a ton more in your anatomy course, which you'll probably either take with me or Dr. Weinhold. So there's a lot, be prepared, but that's all you need to know for now. More airflow is louder. So if you push more air out, that's getting louder, like that. The major cartilages of the larynx, there's 3 that I want you to know. And you don't necessarily need to know where all of them are. You just need to know that these are 3 important cartilages. I just want you to be prepared, again, for your anatomy course. So you've got the cricoid cartilage, which is kind of a circular ring-shaped thing. You've got the thyroid cartilage, like a thyroid gland. And it's not a ring-shaped. It's more like a kind of a large C-shaped kind of thing that fits over top of this ring. And then you've got arytenoid cartilages, which are going to be on the top of the cricoid cartilage. So cricoid, thyroid, arytenoid. These are the important cartilages for you to know for now. They're the major ones for making a sound. So before we get to how a sound is made, a sound wave is just, it's also called a sound pressure wave. So if you think about, so I'm going to clap, right? And if you do that, if you clap right in front of your face, you'll feel air rushing out, right? If you think about when you talk, you can feel air, rushing out. So really, what's happening in this case, a sound wave, is pressure in the air, like pushing on the air. When I do a clap, it's one kind of broadband sound. There's not a good fundamental frequency. A fundamental frequency is like the frequency that you hear. So you might think of it as pitch, a musical note that corresponds to things. So you can talk, low or high, and those are different pitches. But when you clap, it's a broadband noise. There's not a good identifiable pitch. Anyway, that, I guess you need to see it straight on. So the hit forces all of the air that's between. So you've got this air between your hands. You hit them together. The air is forced out on all the sides. And that is the sound pressure wave in that case. So it pushes this air out. As it pushes the air out, it moves through the rest of the air, right? And then it reaches your ear and it pushes on your eardrum. So that is a sound wave. In your vocal folds, and also in some instruments with two reeds are very much like vocal folds. So like a bassoon, a bass clarinet. No, a bass clarinet doesn't have two. A bassoon does. Certain types of, you know what? It doesn't matter. But a bassoon has two reeds. And they'll kind of move with each other and let air escape. And that's exactly what's going on with the vocal folds. So you've got this kind of structure here. So imagine breath is down here, and it's forcing up. And so the vocal folds are going to kind of blip, 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 like that, and let out just little puffs of air. These puffs of air translate into sound pressure waves, and the rate at which those puffs of air escape is the pitch, and then how forceful those puffs of air are is the loudness. That's why increased airflow is correlated with increased loudness, because if you have more air flowing through, it's a larger displacement of air. So the sound pressure wave is greater. There's more pressure behind it. So that becomes a louder sound. And then again, like I said, the rate of the pulses is related to the actual pitch of the sound. So a sound wave is a sound pressure wave. And so literally just the air molecules are getting squished together and traveling along. Kind of, you can think about it kind of like an ocean wave, but it's in 3 dimensions, not just 2. And sound produced from vocal folds is just little puffs of air coming out between the vocal folds. Different shapes of resonators are going to make different vowel phonemes, right? So assuming that your mouth is open, you've just kind of got this like open tube, or E, then you can change the shape of the resonator, and that includes your mouth in this case. So down here and all the way to your mouth, and that's going to make different vowel sounds. So E, like that. That's just changing only the shape of the resonators. Then you've got different stop placement, so P versus K versus T, voicing P, B, P is not voiced, B is, S versus Z, so S versus Z, that's voiced or not. Is the air being stopped, or is the air still flowing? So you've got F versus O, right, or F versus P. So air has stopped flowing in one place or not. All of these create different consonants. And that's just movement of your articulators. Your articulators, in this case, your lips, your tongue, and then also back here in the glottal region. All right. So ethics, welfare of clients is one, like the primary ethical concern. You always want to be able to provide the highest quality service. Remember, that means, a couple things like don't come into work hungover or still drunk, but less obviously, it means staying up on the current research so you can help your clients better. Non-discrimination, again, has obvious and not obvious components to it. So the obvious component is like don't discriminate based on gender, race, all the things that you should never discriminate on. But it also means don't discriminate between clients that you think you can help and clients that might be less likely to progress. So don't give more time to someone that you think is going to be able to overcome these hurdles or more, not just more time, but more effort, and less effort and less of your professional self to somebody who you think is probably like a progressive dead end. So that would also be discrimination. Don't misrepresent yourself or your coworkers as things that you're not. So if somebody is an SLPA, don't say that they're an SLP. If you're an SLP that knows a little bit about audiology, don't call yourself an audiologist. Things like that. Another big one is no false hope. So you can talk about likely prognosis with a client or their family, depending on their if they want you to talk to the family about medical procedures, but medical outcomes. So you can talk about likely prognoses, like, well, we typically see this, and often people, progress within 6 months. What you can't do is tell them, like, yeah, we're going to get you back the way you were. You cannot say that. You can't tell them that you're going to get them back to perfect. You can't promise them that they're going to be able to say the letter S correctly. You don't know. It might not work. So you can, likely prognosis is fine, but don't give anybody false hope. You also have to provide notice of the end of your service. So if you're moving or quitting, or you have too many cases and you have to drop some, you have to let your patients know so that they can find somebody else to go to. And then you've also got a duty to report when anyone else breaks any of these other ethical violations. The next few things are kind of similar, right? So don't misrepresent, like, research findings. The lumosity thing is here because they misrepresented research findings. We cannot train working memory to work in a different area. So if you do a bunch of NBAC tests, you're not going to get better at something that's not an NBAC test. And yet they said that they could do that. So that is a huge misrepresentation of research findings. There's one study that somebody showed that they could, which was then disproved, but the only thing that Lumosity bothered to cite was the one study from a while ago that said, oh yeah, you totally can train these things. So that is huge misrepresentation of research findings. Avoid conflicts of interest. So if you are, this is kind of self-explanatory, right? So like if you own a company, it's kind of weird to do research to show that your company provides better service than a different company and you own it. So that's kind of an iffy area to do your own research and then publish that scientifically because you own the company. I mean, would you publish it if you got a bad finding, or might you unconsciously introduce bias to the results? You certainly might. Don't take bribes. So if there are two products that you might want to that exist, you have no idea if one is better, but you get a kickback if you sell a certain number of product B, which you don't really think is any better than product A. You don't know a lot about them. You should not try to get people to use product B over A because you get a kickback, right? Even if you thought product B was better, you should just not enter the possibility of a kickback, right? So if you think B is better, and if you sell more, you get some sort of special tax credit from whatever company you work for. Let's talk about hearing aids, right? So hearing aid B is better than hearing aid A, you think. And then they say if you sell 50 of them this month, we'll give you a huge tax credit or something like that. Well, even if B is better, that gets into super iffy territory. You can absolutely recommend things if you think that they're better. It's better if you recommend them when you're not getting anything for it, just because you actually think that it's a better service. And then definitely don't recommend one over the other just because something is being offered. Okay, we talked about lumosity. Okay, so what degrees and qualifications are necessary for different jobs? So an SLPA, you need a certificate. An SLP, you need at least a master's degree. An audiologist, you need at least an AUD. Well, you need an AUD to practice, right? And then to do academic research, be a professor. I mean, you can do research with any of these other qualifications. Typically, you need someone who is a PhD to be the principal investigator on the project. So that would be like the lead person, but you can do your own research as an SLP, SLPA, AUD. Oh, I have a phone call. SLPs could work in schools. That's the big one that we know about. There are nursing facilities and also private practice where you might either work for someone that has a business area of their own, or you might go into other people's homes and provide care in home. So those are kind of the sort of similar. I kind of tried to group them into similar, two groups of similar things. I guess that doesn't totally work. But so in the schools, you'd be working with children. In private practice, you might be working with children, but you could be working with older adults. Nursing facilities, usually older adults. There's a lot of swallowing or learning how to speak after a stroke with that. Then you've also got hospitals that can kind of overlap with some of the nursing facility jobs, except that it's more acute. These are people that might have huge problems with swallowing, that they can't live off of a feeding tube yet. So you'd have to really help them figure out what's going on. In the natal intensive care unit, there's a lot of dysphagia, so again, swallowing with very young children. But also in the hospitals, they have people who help look at speech problems with TBI, or so people come in after a car accident, a blow to the head, and they're assessed for their speech proficiency. And then also there's acute care, which is kind of like after the hospital, you go to acute care, and that might be before you start doing private practice. So there's a very similar pattern of jobs that you might do, but they would be in all these 6 different places. AUDs will usually work, they can work in hospitals as well, they can work in private practice, and then much less often than SLPs, but that they can end up working in schools. Usually, though, what happens is the schools will contract out to private practice. PhDs, you can work in industry, you can work at a university, and then also, well, that's industry. I was going to say that there's a lot of people that I am friends with who've gone to work on actual hearing aids, like make the actual hearing aids better for the hearing aid companies, but that's just industry. All right. So we've talked about the main SLP functions throughout. So, speaking for kids and adults, swallowing, accent reduction is another one that we didn't talk about. So those are a lot of the main functions of a speech-language pathologist. This graph, this kind of bleeds into the next slide. This graph is when you typically expect these speech sounds to show up for kids. So the left bar, the left end of the bar, I should say, is when 50% of children have mastery of the sound, and the right side of the bar is when 90% of children have mastery of the sound. So this one here, M, 50% have it at around 1 to 2 years. So, something 12 to, say, 18 months is about the average here. And then 90% have it at the end of 3 years, very beginning of 4 years. So you can see that M is a very early sound compared to, say, J or J down here. J is very late. 50% have it at 6 years, and 90% have it by 8. So it's a much later developing sound. This is the typical progression, what you typically see. And the other thing to note about that is it's hard to say when something is a delay versus a disorder, because this is 90% here and not 100%. So if you have a kid that doesn't have M by 4.5, is that a delay or is that a disorder? It's kind of up to you and the parents and the teacher, and at this point it might not be a teacher. It's up to you and the parents to decide if that is a delay or a disorder. Do you want to wait and see if they get it on their own, or do you want to start therapy and try to develop that? Okay, so for speech development, one of the things that we talked about was the debate between nature versus nurture, or behaviorists and nativists. Nativists would say that language is innate in people, right? So you're kind of born with an innate. That's okay. So if you take 367, if you take language science with me, I definitely talk about this. I'm pretty sure that Dr. Uzuma talks about it too. But yeah, she does. Anyway, it kind of depends on which nativist you talk to, but some of them might say that, like language is just innate. And I mean, with, just a little bit of powdering of which language you're going to be exposed to, it's there. Like all the structure is kind of like inherently there. Others kind of distance themselves from that because it is too magical, which I agree. It sounds way too magical. It's like bordering on, like complete lack of science. And so they'll move a little bit further back from it and say like, well, we are kind of predisposed to think of things in a way that facilitates language, and that seems better to me. Behaviorists would say that it's all kind of like, typical if you've had, a Psych 101 class, behaviorism, but it's all modeling like response to a stimulus. So it's all stimulus response. I want a cookie and someone shows me, here is one, cookie, and now I know, I can ask for cookie and then I get a cookie. And so then it's all stimulus response. You've also got interactionists who say that it is a little bit of a nativist idea and a little bit of a behaviorist idea that are kind of working together. That's where I am, either in the behaviorist camp or the interactionist camp. I think, so I'm probably an interactionist who might weigh more heavily to the behaviorist side, but I don't want to discount all of the nativist stuff. Some of the nativist stuff is just totally ridiculous, though. But that's like the far, like, we just come like pretty much prepackaged for language, which is a little ridiculous. Anyway, the closer, the more developmental nativist stuff is a little bit easier to understand, easier to follow. Okay. The stages of attention development, we talked about. This is kind of like, where do infants want to look? So up to 6 months. they're going to be mostly focused on the face of the caregiver. So mom, dad, grandparents, siblings, whoever's, directly in front of them, that's where their attention is focused. After that, it goes to shared attention. So you can look at things together and talk about other things. So at first it's just on you. It's kind of focused on, who's around, what's going on with them. And then you start to be able to talk about other things with them. Word over and under extension. So word over extension is, I talked about doggy was for anything that looked like kind of wet and black, like a dog's nose. Like somehow the kid had overextended the meaning of doggy to be anything that had any sort of characteristic relating to a dog. And so then there's this black olive in a salad, and she says, doggy. And then everybody's kind of like, yeah, I don't know what that salad dressing is, so we're not going to eat that salad. So that's word over extension. You've also got under extension, where maybe a kid thinks book is one particular book that they really like, and every other book is just something else. They have no idea what it is. So you might say, what's this? And they're like, I have no clue. And you're like, it's book. And then they're like, is it though? Because that other thing that I really like is called book. And they don't understand that book is a generalizable term. They are maybe thinking of it as a very specific book. Children learn tense structure. I don't really mean like how do they learn it. I mean like what are the stages of learning tense structure. This, if you're looking in the slides, is on the WUG slide. So, and those are those little bird-like things. So first, they're going to learn plurals. That's very easy to learn. It's just like WUG, WUGs, or I guess WOJI if you're Latin, maybe. Possessive would be, WUGs with the apostrophe. So, or mine is another thing that they like to learn. So they might learn cookie and cookies, and then my cookies. And then past tense, cookied, I guess. But I'm trying to stay with one word, but it doesn't really seem to be working. And then third person singular. So it's going to go plural, possessive, past tense, third person singular. So plurals first, one versus more than one. Possessive, who does it belong to? Past tense, this happened. And then you've got your third person singular. So that gibberish song that I had you listen to is just to show that babies start to tune in to their own language, to the sound of their own language, before they even understand what the words are. So they know that the sound of English. And then that song that I had you listen to is like, it's the sound of English. Like they're all Italian, but everything that they were doing, like it didn't sound like it had an Italian accent to it. It just sounded like American gibberish, right? So this is kind of like what babies are doing, is they're like, oh, that sounds like gibberish of the kind of gibberish I know. And so then they'll start listening to that and tuning out other gibberish. And that's prior to, it's about 1 year is when they're able to do that. So about 1 year, they'll start to tune out gibberish that doesn't sound like the gibberish that they know, that their caregivers speak. So syntactic development, this is a pretty easy concept, right? So it's going to go from hollow phrases, which is one word, then it's going to go to 2-word phrases, then it's going to go to telegraphic speech, which is 3+ words, and then it's going to go to very simple sentences and complex sentences. So there's not a lot of distinction there, right? So it's like 1, 2, a few, simple sentences, complex sentences. Pretty easy, right? And that's exactly the stage that you would expect. So hollow phrase is like cookie, means give me a cookie. Two-word utterance might be like "cookie me," so you want a cookie. Telegraphic speech, "give me cookie." I'm hungry right now. Maybe you can tell. I haven't had lunch yet. And then simple sentence and complex sentence, right? So speech errors that we typically see are fronting. So speech sounds that are produced more in the front, consonants that are produced more in the front are used instead of consonants that are produced further back. That's a very typical speech error that we might see. Some of these other ones are deletions. You can think of soda, which is going to come up in another slide, but those are very typical errors in development, right? So distortion, a substitution, an omission. So a substitution, an omission, a distortion. I was going to say deletion, but that's the same thing as an omission. So a substitution, an omission, a distortion, and an addition, soda. These are very typical speech errors. And then fronting is a typical substitution that you would see. So w instead of and other things like that. The difference between a delay and a disorder, well, we kind of talked about that. Like sometimes it's hard to tell if it's a delay or disorder. But what if they have an error that isn't seen in typical development, like backing? That's a disorder. So if they are saying g instead of w, that would be a very strange progression, because you shouldn't get consonants that are further back before the ones that are closer to the front. So that would be a big red flag that there's a disorder there. That's a good way to jump into this next thing. What kind of feedback is necessary for understanding speech sounds? Well, auditory feedback, visual feedback, and haptic feedback. These are all really important for understanding speech development. Why do front sounds come first? Because they're easy to see. W is really easy to visualize, but g, you're not really sure what's going on back there, or k, right? So you can hear it, but you're not really seeing how it's made. Whereas w and m and b, those are all, you can watch them happen and hear them happen. And then sometimes parents will like say, no, look, and they'll take the kid's hand and put it on their mouth and go puh, and then they say like, try to do puh, and then the kid puts their hand in front of their face and says puh, and they're like, oh, I get it now, and then they can say puh. So the feedback necessary for understanding speech sounds: visual, auditory, tactile, all three. All right. An articulatory disorder is going to be one that is, a problem with the actual effectors, the speech effectors. So maybe there's not enough. Maybe there's muscular weakness. Maybe there is an inability to say certain sounds. So like cleft palate, you can't say p and b, so you just can't say them. You'd have to substitute in another letter. And then phonological disorders are a problem with the speech, the cognitive process of speech, like knowing the speech rules, or word knowledge problems. So they're very different. Somebody with an articulatory problem might not have any problem with speech rules or any problem speaking normally, but maybe they can't make the speech sounds the correct way, versus, so they never are able to say R. They would always say W instead of R. Articulatory. Phonological disorder, you might have somebody that doesn't understand the speech rules. So a really typical progression that you might notice would be somebody who, so a really good example would be somebody who uses W instead of R sometimes, but then they can say R other times. So So maybe they really like Furbies, and they might say Furby, but then they can say rug just fine, or even furry they can say just fine, but not Furby for some reason. There might be a phonological disorder there. Something's wrong with the rules about speech. They don't realize that it should be the same sound that goes in all of those places where R shows up. Types of articulation disorders, well, again, this is where our SOTA comes in, right? So we have substitution, omission, distortion, and addition. A substitution would be using "wa" instead of "ra." An omission would be just not saying the letter that you can't say. So kick instead of quick would be one. A distortion would be like the lisp that I have, it's not quite the right sound. It's a little bit different when I say S. It's not quite a typical S. And then an addition would be putting in another sound. Usually that's when you have like a cluster of consonants. So backslide might be pronounced backaslide instead of backslide. Not sure that's the best. I don't know how many children say backslide, but that's what an addition would be. So you're adding in the backaslide instead of backslide. So which one is likely to have an identified cause? Most of you got this before I told you the answer, when we were just going over the different types, which is awesome. You should all get it now. An articulatory problem is more likely to have an identifiable cause. So you could have a cerebellar problem, damage to the cerebellum. You might have then weak musculature, so you can't form the correct words. You don't have enough power in the respiration to form the words. Cleft palate would be an articulatory disorder. So the first thing you want to do when you're planning treatment is you want to get speech sample, right? That's the very first thing you want to do, because you want to know how many occurrences of this speech problem do you see? Do you see other speech problems along with it? So is it just R that they're having trouble with? Do they have trouble with R in all the placements? Do they have, really quickly, I should tell you, my furry example it's in the same place. So you wouldn't expect a kid, well, maybe because it's instead of a B, that could be typical. So maybe that was a bad example. But so let's say like few and feel, and then maybe for some reason somebody might say few and seal instead of feel, and that could be a phonological disorder, because it's in the same position, it's at the beginning of a word, it's before kind of an E sound. There's a little bit of a difference in the E sound, but they should be able to produce that the same way. Anyway, because you don't always have kids having problems with the letter in all occurrences. Sometimes it's easier to put them at the beginning of words, they get that, and then in the middle of the word it gets a little lost, or before certain consonants it's harder to produce, say, an R or an L, or again, the clustering kind of thing. So SCH for like school might be kind of hard, but S or C by themselves might be easier. So anyway, when you're gathering the speech sample, you want to see where the problems are. So in what position does the speech problem exist? Are there other speech problems that go along? Does it happen more at the beginning of when they're talking, or more when they're getting kind of tired and bored with what they're saying? Does it happen when they're more excited, so they're paying less attention to their speech, so maybe they just need more practice in that case? So that's the first step. You need to get a speech sample. It is good to get it unplanned. You don't want them to read a passage, you want to just talk to them. The reason for that is if they're reading a passage, they might be going slower and rehearsing the way that they should be pronouncing those letters. But you want to know kind of an off the cuff, like what are the speech problems? Because they're going to show up more there. How do you figure out the extent of the issue? Well, these are kind of like what I just said, right? So you want to look at how often is it wrong, where in placement is it wrong. These are all different metrics that you can gauge how severe the speech problem is. Remember, we also looked at if there's more than one speech problem, more than one, say, phoneme that can't be spoken, you would see not exact, well-sliced differences, but you would say that somebody who says wifujiweda is not too bad, but then a kid of the same age who just says we is really severely experiencing that issue, right? So there's not really cut and dry. If they get 9 correct, they're not severe, they're mild, and if they get 10, they're severe. It's not like that. So it's more kind of experiential, right? And so the more experience you have, the better able you'll be able to say, like, this is a severe case, this is not a severe case. But it's based on these metrics of where is it a problem, is it everywhere, how many different consonants do they have a problem with, is it a lot or is it not very many, how often is this a problem, is it all the time, is it some of the time. So it's based on those metrics. As much data as possible is good, but obviously time is limited, so you just want to make sure that you get at least 2 instances of each phoneme. At least 2. I mean, more is good, but at least 2. Is qualitative preferable to quantitative? We didn't really talk about this very in large detail. They have their benefits. Each one has their benefits, right? So quantitative is great because you might be able to compare that to other kids, except there's not a whole lot of like validated metrics to compare numerically. So it's good to get that data, then you kind of know. So if there is a test, so like let's say Goldman-Fristow, that's a validated test, and you can compare norms that way. So if there's norms, you're good, and you want to have quantitative data. That's really good. There's not a lot of norms for all the different tests. So in that case, you want to go with qualitative. And even so, qualitative is also really good to just give a picture of your client and what is their particular issue. And then you can also have quantitative data to see where they are in relation to other children. So they both have their benefits. You might want to include both. A familiar versus an unfamiliar listener is an important distinction because a familiar listener has kind of learned all of those different speech problems. They're going to be more likely to piece together what the child is saying. An unfamiliar listener doesn't have any idea, and they're just kind of going in blank, and they will have a much harder time of figuring out what any child is saying, much less a child with a speech disorder. This is the sine wave speech example that I had you listen to, right? So at first you had no idea what it was saying. Then you heard the actual speech. It's saying, where were you a year ago? And then you listen to it again. Oh, I get it. Now it makes sense. Before it was just like, wah, 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 wah. And now it actually sounds like, where were you a year ago? So we took you from an unfamiliar listener to a familiar listener in just a few seconds. And that's why we want to look at, are the children intelligible to unfamiliar listeners? Because in life, they're not just going to be around their family. They need to be understood by teachers and other children, and, you know, as they become adults, by everyone else. The silent period is pretty much exactly what it sounds like, right? It's like a period when the second language learner is silent, and they're just kind of like being receptive to the second language. Although like we heard about in the guest lecture, there's some research that might be questioning whether or not how long the silent period is, what's really going on with the silent period. Is there a silent period for everybody? But as far as, since that's being researched and we're not sure, we will still for now assume that it is a thing. So the silent period is when a person who speaks a different language, like let's say it's Arizona. So common would be a Spanish speaker coming to Arizona, doesn't speak English, and their silent period would be they're just kind of being quiet, taking in information, and kind of piecing together, oh, this word means this, I understand that, and then eventually they'll just kind of break out of the silent period once they've kind of like immersed themselves in what's going on. The bad thing is it can look like autism or other communication disorders, right? Because children with autism don't speak. They're kind of silent. And it's possible that due to the current climate surrounding people who speak different languages, some of these children might also be kind of embarrassed, or not necessarily, well, they shouldn't be embarrassed, but they might be. But they might feel awkward around other people who do speak English, and so then they might avoid eye contact as well. And so the silent period can very much look like autism. So you might end up with someone who is totally fine, they just speak a different language, that's getting services for autism, which is not great. So when do we expect typical conversation in the second language to develop? After about 12 months. But the problem is we don't go to school. Well, we're in college, but children don't go to school for 12 months, right? They've got 3 months off for holiday. So you need 12 months, and then typical conversational L2 will develop, but school is only in session for 9, and then they go home, and if they're spending time with their family who speaks Spanish at home, and not the conversational partners that they had in school, now that gets set back a little bit. So it doesn't show up after 12 months. If you have someone who's assuming that they should be at typical conversational level in 12 months, and they're not taking this into account, then they might think that this child has a speech delay or speech problem. But really they don't. It's typical development that's been interrupted for a holiday break or a summer break. Some of the techniques, if you are an SLP who doesn't speak the L1, one of the things that Asha says is, like use interpreters. Essentially, what you want to do is you want to try to provide the best, this which goes with the ethics guidelines too, right? You want to provide the best care possible that's kind of like within your realm. So the best is if you speak the language. But if you don't, then you can find someone who does, like a different SLP, and have them work with them. But maybe that doesn't exist. So then you can use an interpreter who can actually be there, and that's great. If that doesn't work, there's phone interpreters that can be used. You can even use someone else in the community who speaks that language to come in and act as an interpreter. And you kind of want to go down the list in that order. But anyway, one technique is using an interpreter. Another technique is using someone at the school or a parent in the community that also speaks to act as an interpreter. So the types of bilinguals, there's a couple different ones. You've got sequential. I want to talk about simultaneous first. You've got simultaneous bilinguals who are learning 2 languages at once, right? So somebody who, like, let's say the home speaks both English and Spanish. They might learn both at the same time. And then you've got sequential bilinguals, but that's kind of broken into 2 different parts. You've got early sequential bilinguals, and that's you start your second language around 3 or 4, and then late sequential bilinguals, and that can even be like as an adult you learn your second language. So simultaneous, Early sequential is offset just by a little bit, and then late sequential can be offset by a lot. And then you've got a couple breakdowns of like, is it circumstantial, like you have to learn the second language, or is it elective where you wanted to learn it? I'm not going to ask you about that. What would be on the test is like simultaneous, early sequential and late sequential. And who's most likely to code switch? The simultaneous bilinguals are most likely. But anybody who has a really good grasp of both languages is likely to code switch and just kind of jump back and forth between the two languages. If you're not super confident in both languages, you'll have one language that dominates, and then you're not as likely to code switch. Interestingly, you do see, like outside of just bilingualism, you will see code switching in like the ways that you talk to other people. So we kind of talked about this, like you might have an accent that like turns on when you start talking to somebody that you know who has the same accent, right? This doesn't happen to me because I didn't live in Alabama long enough, I think. I've just gotten rid of my accent entirely. I was born here, moved to Alabama for a while, and then I came back, and I had a very thick Southern accent. But I do have a friend who's from, Tennessee, and she sounds, pretty much not as like relaxed California or Arizona as I do, but pretty just standard. And then we would go to conferences. She would meet somebody else that she knew from the same school she went to for as an undergrad, and then it would just like immediately click into this other language, essentially. I mean, they're using, it's not just the accent. There's like slang and all sorts of stuff, and I'm like, okay, I'll be over here and not in this at all. And I do it with my friends also. So like we're doing research, but as soon as we go to the bar to continue planning our research and stuff like that, the way that we talk definitely changes, right? It gets a little bit more R-rated. We use a lot more colorful like metaphors and stuff, and it's just totally different. We don't use the high-level academic language as much. So that's very much a code switch. We're here and we're working, and then we turn on the academic language, then we go to the bar and we turn off the academic language and turn on the, whatever you call that. But so it happens outside of just bilingualism, but it does also happen inside of bilingualism. Does L1 intervention cause delays in L2? There's absolutely no evidence that, again, L1 and L2 is good to know. L1 is your native language, and L2 is the one that you're trying to learn. But there's no evidence that if someone is a Spanish speaker, that giving them intervention in Spanish delays their learning of English. As long as there's sufficient, instances of both languages, they'll still develop. So as long as they're getting a lot of practice in English, they'll develop English. It'll be fine. So if they get intervention, like let's say in math or in science or something like that, to help them understand some concepts and actually do the other things that they should be doing in school, that the laws that say you can't teach in a second language make impossible, then they'll be fine. They'll be totally just fine. And it's kind of ridiculous that we're the only state, especially we border Mexico. It's really ridiculous. So anyway, but no, there's no evidence that L1 intervention delays L2, or intervention in L1 delays L2. No evidence. All right, so autism, we'll kind of run through. I've got 2 slides on this because we had 2 lectures on it, so we'll start with children and then we'll move to adults. Earlier, I said that form, use, and content map onto other things that we've talked about. So form maps onto phonology, morphology and syntax. Use maps onto pragmatics, and content maps onto semantics. One of the big things that people with ASD have trouble with is the use, the pragmatics, right? It's hard to get the social cues, all the different things. So that's where the issue comes in with them. Boys have a higher rate of ASD than girls. Why? Well, possibly just the way that they externalize their symptoms. It's more obvious, and it might not be as obvious for girls. We also see this in communication disorders, and once again, it's possible that this is a similar reason. It's just more obvious in boys because they're louder and they externalize their symptoms more. A girl who has a communication problem might skirt around it and not use that sound as much, so it might be less obvious, possibly. And then with this, they might be just quieter and kind of skirt around the autism diagnosis. But there's other possibilities as well. It could just be that somehow it's possibly genetically related. But certainly with autism it could be. But again, there's a lot of things we don't totally know about autism, so it's hard to say. So are rates of autism diagnoses rising? Yes. I mean, the rates of diagnoses are rising for sure. No doubt about that. Now it's 1 in 59. It was 1 in 68 last semester when I taught this class. So that's pretty crazy. That's the incidence. But why? Well, it could just be that we're more accepting of it. We know what to look for. We're tagging these things a lot earlier. It could be that more people are getting it, although it's likely that we're just seeing it earlier and better at identifying it. But it could be that there's some sort of environmental thing that is causing a rise. Could be. There is really no typical person with autism, right? I mean, there's a whole bag of different symptoms that could happen, even in sensitivity to stimuli. You've got people that are very overly sensitive to things, and then you've got people that are very undersensitive to stimuli. So, there's no typical look to autism. Some of the disorders that can co-occur with autism, sometimes Down syndrome, then also depression, anxiety, hyperactivity, and sometimes OCD as well. So a lot of these things. Also sometimes some sensory processing issues as well. And then the biggest speech problem for ASD, we talked about this, it is pragmatics or use, right? It's just kind of the social component of the speech act, if you want to say it that way. Okay, so the history of research on ASD in the elderly, not very great, right? And one of the reasons for that is we just weren't noticing how many people there were, right? The very first person who was diagnosed as having autism was in the 40s, and they're just now in their 80s. So, it's not like it's a disease that we've been able to look at for a long time. It's a new field, looking at ASD in the elderly. And it's going to grow more because, again, autism wasn't in the DSM until 1980. So there were a few people that were diagnosed prior to that, then a lot more in 1980. And those people haven't gotten to the elderly age yet. So it's not a good amount of research that's been done on it because there's not a whole lot of people. We know that there are. It's just hard to identify who they are now. But it's good to have the research in place for when this whole large group of people that were diagnosed after 1980 end up aging. Similarities. Oh, I've got kind of the same question 3 times here. So, similarities in the brains of people with ASD and the elderly, and then the deficits in ASD and aging. essentially these are all going towards the same point. So you can really obviously see where the question is going to be on the exam, but it's a frontal lobe deficit mostly, right? And so frontal is where a lot of your planning, decision making, your kind of higher level cognitive functions are happening. Those, you see a lot of deficits in people with autism in the frontal lobe. As people age, you see more deficits in the frontal lobe. And so it's possible then that as people with ASD age, you have a much larger problem in the frontal lobe. What is overpruning? Well, this might relate to what goes on with people with autism as they develop. So the graphs show that people with autism have greater than average brain capacities at birth or just after birth. And then once pruning happens, which can happen sometime between 7 and 11, 7 and 12 possibly, pruning essentially is just cutting neural connections. It happens to everybody. It's not like it only happens to people with autism. We just got a ton of neural connections. Some of them are useful and some of them aren't. And so then they're trimmed, essentially, by a natural mechanism in the body. And so overpruning might happen to people with autism. So they have larger than normal brain size, and then after pruning, it goes the other way, and then they have lower than normal brain size. So it could be that it's just taken a ton of stuff out. Connections that had been made just get wiped out. All right, so that's overpruning. And I think that's the end of the review. If you have questions, you can email me. And then also, Amy and Abby are holding a review session on Wednesday in 2255 from 1 to 3. Your exam is from 3 to 4:20. I'll bring Scantrons for you. So all you need is a pencil. Definitely make sure you have a pencil. And you might want an eraser too. So that's all you have to bring. Pencil and eraser. And I'll provide everything else. All right. Good luck.